So, we've talked about need for education and training for the care team, and the role that different providers can play. What do you think are the skill sets that are required of the clinical team? Who in the clinical team needs to be trained? What can we do to make these training accessible to everyone? Because as you and I know today, it's not part of um, our core curriculum. It's not part of our training. Um, so how do you think we can make it more accessible?
So I think the real struggle is that there's no mandate for
Mm-hmm,
a gold standard of a palliative care team,
mm-hmm,
right? I think that's really where we have to start, which is
right.
why every hospital kind of makes it up on their own as to what their composite of the team is going to be, who's
Yeah,
going to lead part of the team, how
yeah,
much time or FTEs they're going to devote to the number of people on the team. And
yeah.
that's what really is, I think, the main impediment
Mm-hmm,
to having a coherent and structured care team, because the care team itself supports itself. They become like an inner circle of therapy for each other, for the acuity of the patients they're caring for. And if
right.
you have a disparate group of people who aren't always there at the same time, aren't well supervised, that's where things kind of go off the rails, and you get varying degrees of competency in different programs. And
Mm-hmm,
so, as a consequence, across the country, you can have programs that advertise and brag about their palliative services. But
mm-hmm,
then when you read the fine print, they may have a social worker 2 hours a week, or they may have a chaplain who's running the team, which is wonderful, but they're only available 2 days a week. Whatever it is, it's not what it sounds like or what it should be.
So what we've been doing is we're teaching the gold standard of
mm-hmm,
what it should be.
mm-hmm,
And unfortunately, we have we have both been educated in the gold standard of the way it should be presented,
mm-hmm.
but unfortunately, with cost limitations, reimbursements, it's not. Each hospital has their own way of providing palliative care.
Right.
And that's the one thing, there needs to be a certification for hospitals that offer this, so patients know, am I going to a center that meets the gold standard?
Mm-hmm,
Like, for example, you go to some hospitals and say, oh, we have the gold standard in heart transplantation or in breast cancer or in or whatever. But in palliative care, we don't have that. And that is really a tremendous disservice.
mm-hmm.
And the
Yeah.
one thing that Donna just mentioned is, if even with a gold standard palliative care practice, there's an element of debriefing that is so critical. I mean, when you have a very difficult case, and it really weighs on all the practitioners who are involved,
Mm-hmm.
because we all feel it. We
Right.
feel it. But the fact is that after you take care of this patient, you have to get together as a team and talk about how you're coping with it, because otherwise you can burn out very, very quickly.
Mm-hmm.
And so that's another aspect that has to be emphasized is the debriefing after they care for a very difficult patient.
Yeah, for sure. The concept of second victim
Mm-hmm.
is something that all palliative care providers are very sensitive to, and why the debrief and the cohesiveness of the team becomes so important. So it needs to have the support of the administration. It needs to really be part of the culture of the hospital, because if the impetus for palliative care is not built into the culture of the hospital, then there's always going to be going up against more barriers for delivering this kind of care, because people automatically have the inherent discomfort with dealing, as you mentioned, the I used to be called Dr. Death, so I understand what they referred to you in a similar fashion. But I didn't mind that, because you know what, this is a skill set. It's people weren't born with this language. It's a skill set, and there are programs out there like OncoTalk, Vital Talk, Ariande Labs up in Boston. They're going into nursing schools. They're helping train not only physicians but nurses and other healthcare providers in the ability to have these skills, to develop these skills, practice these skills, so that they don't, feel like they're being put on the spot to have a conversation they're not comfortable with. And that's the reason why people use euphemisms like, Dr. Death, because they're not comfortable, right? They don't have that skill set. They think that, what's wrong with them? They can talk about it. Well, there's nothing wrong. We actually were trained. So if we had good training programs like what Robin is supporting at Fairfield, this is how we change the culture, right? One person at a time.